Good afternoon. I'm here on the third day of SOHO. I have a great pleasure of having the Best Abstract Awardee in the Multiple Myeloma section. I have Dr. Taxiarchis Kourelis, who is currently doing an advanced fellowship in myeloma at the Mayo Clinic, Rochester. Welcome, Dr. Kourelis.
Thank you, Dr. Iyer. Thanks for having me, and thank you for giving us the opportunity to present this data set of patients with localized amyloidosis at the SOHO 2015 annual meeting.
Thank you. If I might call you Tax.
Sure, yes.
Certainly. So it's a very interesting presentation that I saw of localized AL amyloid. Just to put things in perspective, amyloidosis is such a heterogeneous disease, and you are actually describing for the first time one of the largest series so far, if I'm correct, in the public domain of localized AL amyloid, correct? So if you can put this into perspective, yes.
Yes, we have assembled a cohort of patients with localized amyloidosis. You know, one of the limitations, and we did talk about that in this morning's presentation, is that many of these patients did not have typing. So 60% of patients did not have typing for their amyloid. So by typing, we mean tests performed in order to identify the exact protein causing the amyloid deposit. So it was a difficult sell, if you wish, to say that all of these patients were indeed light chain amyloid. And keep in mind, this was a limitation that was mostly coming from the fact that many of these patients were diagnosed in the 60s, 70s, 80s. So we describe a 50-year period of patients seen at Mayo. So back in those days, the only thing we had to identify amyloid deposits was a Congo red stain. Now we have immunohistochemistry, mass spectrometry tests that can specifically identify the proteins. So for 40% of patients, we have accurately identified the proteins, but for 60% of them, we don't. So again, it's localized amyloid. Chances are most of these patients, based on what we know about the tissues that we ended up with, are indeed light chain amyloid, but a fair amount of them might be other types of amyloid also.
So if you want to help us define this entity, the localized amyloid, and you had a set of criteria for both AL and the non-AL type.
Sure. So one way to look at amyloid is amyloidosis. So amyloidosis is it's a weird but fascinating disease at the same time. So it's a protein misfolding disorder, and the question is, where do these proteins come from? So one way to broadly categorize it is light chain versus non-light chain. Light chain amyloidosis comes from monoclonal plasma cells. So plasma cells that, in the case of systemic light chain amyloidosis, come from a plasma cell malignancy, so from a type of blood cancer. It's a sister disease to multiple myeloma. And the treatment for that is systemic chemotherapy to kill these plasma cells. Systemic amyloidosis can also come from other types of proteins, the most common of which is probably transthyretin, or TTR, more specifically wild-type TTR, because you can also have mutated TTR. And this is a protein that is normally produced by the liver, and for some reason in some patients turns into amyloid. And there are other types of amyloidosis too. Another way to look at amyloid is systemic versus localized. So again, systemic, you have the protein of interest is produced systemically. So for instance, the case of TTR in the liver, in the case of light chain from plasma cells that are hiding in your bone marrow. But in localized amyloidosis, it is produced locally. So again, localized amyloidosis can be light chain or non-light chain. Light chain localized amyloidosis come from a localized plasma cell clone. Why does this clone arise? We don't know. How come it stays localized? We don't know. However, we know that if you do biopsies in these patient samples, you see monoclonal plasma cells there and only there. Non-AL localized amyloidosis come again from proteins that are produced locally, and I did mention some examples in this morning's talk. So you have these are very rare cases, I have to say. So you have cases of atrial natriuretic factor, which is a protein produced in the heart, cardiac atrium. So it's one of the chambers in the heart. And for whatever reason, in some cases, might stay there as amyloid. So if you consider that localized light chain amyloidosis is defined as, so these patients, I should say, have no no evidence of a circulating plasma cell clone. And what do these plasma cell clones produce? They produce monoclonal proteins. So tests such as their serum and urine immunofixation should be negative, their free light chain level should be normal, and their bone marrow biopsy should show no evidence of clonal plasma cells. If we see that, then we should really be suspicious that there might be a systemic component or systemic disease, which is an important distinction to make because, systemic light chain amyloidosis is a deadly disease, and localized amyloidosis, as we described this morning, is for the most part, a benign condition that can cause problems, but it certainly cannot kill you.
So as I would imagine, the clinical presentation for these patients, they come in for something, they get a biopsy for something else, and you find this plasma cell clones or clusters, and then you do the staining. Is that how they present? For the most part, as an incidental?
Two ways it can present. Yes, 44% of patients, so almost half of the patients came in with no symptoms at all. They just had an incidental finding of amyloid. So to give you an example, many patients had a routine colonoscopy for colon cancer screening, and in one of their polyps, they had a Congo red stain for whatever reason. The pathologist might have identified some area of concern. They stained it with Congo red and identified an incidental finding of amyloid. Then, some of these patients had a complete workup and no systemic clone was found, so they were labeled as having localized disease. Some patients have localized lung amyloidosis, so they might, for whatever reason, get an X-ray or a CT scan of the chest. They find nodules that are usually followed, for instance, or get biopsied or excised, thinking that there might be a malignancy going on, and we end up finding amyloid. So a fair amount of these patients are asymptomatic. Now, 50 to 55% of patients, however, do present with symptoms, and sometimes this disease can cause significant morbidity. Most of the morbidity comes from patients that have, for instance, bladder or ureter amyloidosis that can present with hematuria, so blood in the urine. Patients that have involvement of the respiratory tract, their lung parenchyma, their trachea, their bronchi, their breathing pipes. So these patients can present with cough, shortness of breath, so significant symptoms.
And obviously, this is the largest series, as you mentioned earlier. And how many patients and how long of a follow-up you have so far?
So this is a data set that's still maturing, and I'm hoping that over the next 2 to 3 months we will have completed analysis and abstraction of data. But so far we have data for patients that were seen in Mayo from about 1965 in this series up until 2014. It's a very heterogeneous patient population in terms of diagnosis periods. And we started abstracting data from patients that did have electronic medical records. So we're biased because we have a more recent cohort. So the follow-up of these patients was, what we have so far is only 5 years. And I say only, but on the other hand, if you think that these patients might come in just to get a second opinion and then they get diagnosed with this relatively benign condition, they might or might not follow up. I think it's still a decent amount of follow-up for these patients. Having said that, we had complete follow-up for progression and survival. So essentially we follow the patients up until their death or up until end of study period, which was 2014, for only about 40% of patients.
Excellent. So in your review so far of this 5 years follow-up, what have you found in addition to the criteria that you use to measure the local amyloid?
Sure. So the presentation, we did mention that a fair amount of patients present with no symptoms. The symptomatic patients purely present with symptoms that come from the system that was involved. Another interesting point is how did these patients evolve over time? And we found that many of these patients, 80% of these patients, had no progression in the future. So, they presented with hematuria. They were diagnosed with this localized bladder amyloid. They had their amyloid excised, for instance, and then this never came back. But approximately 1 out of 5 patients, their disease tend to come back.
Local recurrence.
Local recurrence, yes. So we considered both local and systemic recurrence. And we did not find any systemic recurrence. So that's another point we'll make. But 1 out of 1 out of 5 patients, so 20% of patients had local recurrences, and these sometimes were problematic. Because we need to consider, the treatment options we have for this disease. We don't have, chemotherapy has no role, for instance, so we're quite limited. What can you do? You can, cut it off. In some cases, radiation has been tried because it can kill these, plasma cells that produce the amyloidogenic protein. But some of these patients run into problems, and it can be a major quality of life issue because it can keep coming back again and again. And actually, about 20 patients, so 20 out of 100, so approximately 20% of that 20% that the disease tends to come back. It tends to come back again and again. Some patients had 3, 4, 5 recurrences sometimes, and it was a difficult disease to manage.
And for the most part, as you said, it's a local disease, and the treatment consisted of choosing some form of local therapy, which is the most common local therapy that is used.
Yes, so more commonly, and again, we haven't yet made analysis by diagnosis period, because back in the 60s, 70s, I guess the treatment modalities were quite different, but the most common form of treatment was local excision of the amyloid deposit that was causing problems, and that was good enough for most patients. Upon recurrence, again, local excision was the most common treatment option that was tried. Significant number of patients, they didn't have symptoms significant enough to warrant any treatment, so they were just observed. They might have had, some tiny skin amyloid deposits that didn't do much, so they were just observed, or they might have had some minor supportive treatment. Again, in cases that the respiratory system was involved, especially tracheobronchial cases, radiation was sometimes was tried, and the rationale was, again, just kill off these, plasma cells that are driving this process. But so these are the 3, I guess, major management approaches: watch and wait, excise,
or radiation in very symptomatic situations.
Yeah.
Excellent. So I guess you have a lot more work to do. You're going back all the way to the 60s and abstract the data.
And it's going to take us a little bit of time, but as I said, the data set is still maturing, and we'll have to probably stratify patients more carefully according to, treatments used, diagnosis period, baseline comorbidities, and other factors that are important.
Excellent, Dr. Kourelis. I guess you and your mentor, Dr. Dispensary,
Yep.
A lot to say about defining an entity, which is going to be useful for a lot of the clinicians who encounter this once in a while and what to do. So thank you for elucidation.
Thank you. Thanks for having me.
And all the best.
Thank you.